Anybody online? Just the three of us? Okay. Okay, we'll call this meeting a regular meeting of the Boulder County Board of Health to order. Time is 5:31. The date is October 10th, 2022. We do have a well, actually, I don't even remember how we did this in person. Did you guys introduce yourselves? Please go ahead and introduce yourselves, board members.
Brooke Harrison, board member. Wendy Hinman, board member.
And we do not have any board members on the call tonight. So we do have a quorum and we can proceed. Item number 1 is public comments. Jordan, I think you have that, right?
So we had 2 people sign up, but I only see 1 available, and that's Carolyn Beninsky. So Carolyn, I'm going to make you a presenter, and once you're unmuted, you'll have 3 minutes. You're still muted, Carolyn. We can see you, but we can't hear you. So the mute button's up at the top. That's at least where it should be. I can't unmute her, so.
If she's presenter, she might have a little box. And a little.
There you go. Is
There
that
you
it?
go. Yes,
Yep,
you're
I can
good.
hear you.
Okay, I apologize for that.
You're good.
So my name's Carolyn Beninsky, and I'm representing Novax Mandates Colorado. And we're very concerned about the safety and efficacy of the COVID-19 vaccines. Studies are now providing an abundance of evidence that the COVID shots are neither safe nor effective in stopping transmission or infection. And we'll send you a link to some of those studies. The experimental COVID program, injection program should be halted immediately and all shots pulled off the market instead of the promotion of booster after booster. We're concerned about the safety of Boulder County children and residents who are receiving these experimental products. We recently sent several questions to Lexi Nolan and the board in regard to the COVID vaccines, and we request an answer to these questions. I will read some of the questions now. The focus groups referred to in the questions are the recent groups that the county held to try to overcome the vaccine hesitancy of parents in regard to the COVID-19 vaccines. I won't have time to read all the questions. I also, I guess, would like to know before I get into that, when the Board of Health will be holding their meetings so that the public can actually come and see you in person. So the first question is, and we feel all this information is public information and should be shared with the public. None of it is about any person or personnel issue or parents' personal information. It's all public information, we believe. Number 1, what specifically was discussed in the focus groups? Are there written or digital materials that were produced in preparation for the focus groups, such as instructions for staff and facilitators of the focus groups, or emails to parents? Could you, I'm going to skip some of them because I don't have time. 3, could you send us a summary of parental concerns gleaned from the focus groups? 4, what educational communications and materials have you developed to share with parents as a result of what you learned?
30 seconds.
Okay, so we have sent these questions. We put them in your portal a couple of nights ago. We sent them to Lexi Nolan a couple of weeks ago. So we are requesting that these questions be answered so that we can share them with the public. Thank you very much.
And next we have Ryan Scott. So Ryan, I'm going to make you a presenter and you'll be able to unmute. And once you unmute, your 3 minutes will start.
Hi, this is Ryan. Can you hear me?
Yep, you're good.
Great, thank you. I appreciate it. Thanks for the opportunity to speak again. I just wanted to follow up, and I think as long as your group continues to promote these vaccines, then you deserve an opposing viewpoint. Just highlighting kind of the obvious things that are coming to light now, as you see other countries that are giving the axe to the vaccine program for everyone. And I think this is born out of your group's judgment in pushing forward your vaccine program, requiring that for every business around town. You made lives very, very hard for the last 2 years, and unnecessarily so. So that was very unfortunate. Do not try and do that again. That was a mess up. You should have publicly acknowledged that you made missteps with locking everyone down and all the abject failures along that line. But just kind of undue harm to kids as well. I'll mention Australia has essentially ended its COVID vaccination program for healthy adults under the age of 50 and effectively banned the shots for people under 30 unless they have severe chronic illnesses. Not once throughout COVID did anyone in Boulder County Public Health ever advocate for better health overall, even though we know that COVID most adversely affected those with serious comorbidities, namely obesity. So that was very unfortunate. I not once listened to any of your health guidance throughout, and I feel healthier and happier because of that. So Australia, Denmark, Norway, all countries that are coming to their senses, banning these shots, if not advocating for their usage with certainly younger age groups, kids, or I'll say anyone under the age of 18, under the age of 50, very low risk all in all. So your group, it's very unfortunate, but you proved yourselves to be very one-sided with your guidance. We get your money's dumping in from pharma, but it was just unfortunate to watch unfold, let alone your predatory practices with businesses around town where you tried fining, doing whatever you tried doing on that end. But I spoke with enough business owners to get an idea of that. Norway's guidance, just to be clear, said no one under 65 should receive additional shots unless they were at an underlying risk of severe disease. Yet you guys keep pushing boosters on the general public, let alone kids who, through your own admission, are hardly at any risk of an adverse outcome from COVID. I call that total nonsense. So I'm here to namely call you out on all these things. You've done a terrible, terrible job of recognizing where you went wrong through this pandemic. I think if you review a lot of your discussions with experts and folks you're working with, that guidance was terrible. Thank you.
Jordan?
Yep, that's it.
Okay. Thank you. Now we will go to item 2, which is approval of the September 12th, 2022 regular meeting minutes.
Brooke, I will move that we approve the regular meeting minutes from September 12th, 2022. I second.
Okay, motion and a second. All in favor?
Aye.
Aye. All right. Looks like, did we switch the agenda order up?
Yeah.
So we're going with number 3 first, right?
Budget
Okay,
studies.
budget study session preview.
Can I ask a quick question about internet?
Sure.
So Boco Gus.
Yes.
Okay.
Okay. Is everyone else's working? Mine just says no internet. Okay. Okay, that's all right.
So sorry.
That's okay. Thank you.
Thank you. So we are glad that we've been able to set a date for the budget study session. And tonight we'd like to hear a little bit from Catherine Palmer, just to give you a little bit of a preview about what to expect in that study session and her progress lately with her team.
Hello, Catherine, go ahead.
Hello. Good evening, Catherine Palmer. I think I'm echoing a little bit.
Sounds okay here.
Okay, good. So as Lexi acknowledged, we had initially planned to have our budget work session in August and shared some details about the status, asked for a little bit of a postponement, which we appreciate you guys providing to us. So we are now rescheduled for November 2nd. We wanted to give you a little bit of insight about the work that has occurred since that time. So we've had the ability to clean up and complete finalization of the internal grant budget planning templates. We have updated many personnel financial aspects, including all positions, position numbers, parsing out funding strands, our FTE count, the location, actual vacancies, and hourly rates. We've had the ability to review and relink many of our indirect rates that impact our overall budget, as well as application of those indirect rates. And we've been able to ensure formulas account for all aspects and tie into our reserves and overall fund balance. We've also done quite a bit of work with the county. So specifically, we have crosswalked county funded position records with our own to ensure an alignment. We have also filled in the updates on the compensation components that the county recently made. This includes the $2,400 bonus for the year for salary, a 5% increase in salary for both hourly and salary positions, a 2% discretionary increase for salary for those past their 9-month introductory period, all of these starting January of 2023. So we had to apply all of those into our budget preparations for 2023 as well. In addition, working with the county, they have started a new budget system. So they just unveiled this in July. It's called OpenGov. So we have received trainings from them and are continuing to receive more training so that we can start inputting budget components. And then on top of that, the county has provided provisional initial budget figures. So they're typically the same as last year, except for with the compensation impacts loaded for the county funded positions. So then we want to acknowledge what we're still working on and working to wrap up. So we are continuing to ensure that those changes in relation to the compensation components I just identified with you are going into those internal grants that we had previously completed. We will be doing individual line item review with programs. We are completing a compilation of necessary program exception requests, as well as breaking out an understanding of our discretionary fund and application of those. So for the upcoming budget session, I wanted to share a little bit with you about what you have seen in the past, and then ask if there's anything that you would like to see more or less of. So in the past, what we typically show you is a very large Excel spreadsheet listing all the orgs, funding categories, and funding amounts. We also provide you with a budget session book and PowerPoint that is a little over 10 pages or slides. This includes a high-level org chart, a budget calendar, a comparison of the revenues versus the expenses by each division or section, as well as one by year, so revenue versus expenses by year, as well as revenue versus expenses by funding source and expense category. We also provide you a percentile breakdown of the funding sources, a percentile breakdown of the expense categories, a comparison of FTE changes by program over the last 4 years, a review of the unassigned fund balance figure and percentage comparison, a fund balance detailed list, and a glossary with acronyms. So that is the compilation of what we typically provide you and review during the budget session. Based on that, I'm happy to go over any of those because that's quite the list, but wanted to get any thoughts from you all about what you would like to see, any of those that you would like to keep, any of those that you're not super interested in. How can we make this a beneficial budget work session for you all?
So Catherine, I can't remember from last year, but what would be helpful is a more high-level budget change for each department. So comparing, say, the last year-over-year changes for the last 2 or 3 years in those department budgets, that would be helpful. I think before we were maybe provided it line by line, but if we could get it, more of a top-level department by department comparison. And then also if we could have a quick, couple bullet points of trends. What are the trends of the changes? Does that make sense?
Yep.
Yeah.
Yeah, I think with regards to trends, there was a little kind of up-down snap line graph.
Mhm.
Assuming that's still part of your package. Yeah.
Yes, that's part of the initial. Again, if you'd like it to stay in, happy to keep it. And if it's not beneficial, happy to take it out.
I like to see it only because usually you're looking at the 2023 number and you want to know quickly just like how does this compare to the last couple of years. So I think just that quick visual is helpful for me.
Got it.
And Catherine, this is Lindy. So I haven't been through this before, so forgive me if you already stated this. This exists in the report, but do we get a vision into from previous years, the previous year, I should say, where we have under or overspent in specific areas? So getting a sense of where we budgeted versus where we landed.
Based on the documentation I have, there is an overarching that's provided. So we do a comparison of revenues versus expenses by section.
Mm-hmm.
So it's a little bit kind of like Brooke was identifying. It gives you that overall rather than a granular.
Okay. Got it. And then in terms of the financial indicators, the health and welfare of the organization, are revenues and expenses the primary financial indicators? Are there other things that you guys look at in terms of, and there are other things that from a county perspective are also critical?
Yeah, so revenues and expenses are going to be a big component of that, but specifically for our entity, as well as most governmental entities, our reserve balance is going to help identify also the health of our agency. And as long as we're able to stay within a certain amount, that helps us in case of emergencies, or if we have other things that arise, that helps us identify. And we do go over that in a couple different ways. We also break out in that fund what we've set aside money for. So for example, in the past, Jeff Zayak had asked you all for an increase in the emergency amount. It had been $250,000 and now it's $500,000, and that sits within our fund reserves. So we do hold a line item for that to, again, ensure the health of our overall budget and our ability to respond.
Okay, great, thank you.
Yep.
Catherine, another question. How easy will it be to determine what was temporary COVID funding? Like, so some of the departments some of the departments appear like their funding's decreasing because of COVID changes? And will that be highlighted? Does that make sense?
It does. I don't think it will come across that way in the budgets, though.
Okay.
And the reason for that is because when we received our COVID funding, which largely came from ARPA, as well as before we even received our COVID funding, we had all of the different groups bill to a specific org that was outside their own. So it was called a special org. And so it would not impact their specific org. And then we would be able to monitor and reconcile to that one alone because it was an overarching that impacted the entire department.
Got it. Thank you.
Thanks, Catherine. I would just add that it's always helpful to have, for you to pull out sort of, here are some bullets of things that we should pay attention to that are, noteworthy from the budget report. Like a highlights page. And then the other thing I have found really helpful in the past, and I don't know if the county's budget office produces, a one pager or a short set of slides that talks about the overall financial outlook for the county, because we get so much of our budget from the county. It would be helpful to know, has the county's budget increased year over year? Are they anticipating that will continue? So anything like that that gives us a sense of, because again, I think we've talked about our budget, somewhere around 40%, give or take, comes from the general fund. And so understanding how the general fund may or may not be impacted year over year, just if they have something like that, that would be helpful.
Yes, Morgan, they do have something like that. And originally back in August, we had planned for them to come along so they could do that presentation. I know Jordan has reached out to Ramona or Aaron to see if they would be able to make this one. If not, I'm happy to touch on it, just giving the caveat that I am not the subject matter expertise in the county's components. So I'm happy to go over it, but I may need to reach back out if you have specific questions.
Yeah, that's great. I appreciate it. Thanks. And even just, you don't have to spend too much time on it, but just if it's included in our material so that we can take a look at it, that would be great. Thank you.
Yeah, I think the one thing about the county level presentation, it was usually there would always be these kind of nuances with tax assessment years or property taxes, and some years made it go up, and some years I won't say made it go down, but it was definitely enlightening to see that. So even if it was just sharing that presentation during the budget study session and just pointing out a couple of those things, not walking through the presentation, unless Aaron or Ramona are available, I think would be helpful.
Okay.
All right.
One question for clarification for Brooke. You said a breakout department by department, and I'm assuming you mean division?
Sorry, yeah.
No worries. Just want to make sure I got it right.
Yeah.
All right, and the last thing I want to check on is, of that list that I shared with you, is there anything that you're not interested in seeing?
No, I think it's probably you haven't, somebody has interest in that information. It's why you kind of put it together, right? So we realized that with staffing shortages and the changeover, that you're behind. You were kind of, August was probably not realistic. So I just want to encourage you to do whatever makes the team's life easier. We don't need to go, add bells and whistles, that we know you guys are under constraints. So we appreciate that.
Appreciate that.
Okay.
Thank you.
All right. Well, I guess we'll see you November 2nd then, Catherine.
Sounds great. Looking forward to it.
All right. Us too. All right. We are on to item 3. No, that was item 3. Item 4 is the public health workforce challenges, current and projected issues at U.S. and state levels.
Good evening. We picked this topic for tonight's Board of Health meeting because it's something that feels like it keeps coming up in our conversations, both in terms of retention, in terms of recruiting, in terms of are we set up, and it felt like just a great opportunity to all get on in the same space about what's happening in the United States, what some of the research is showing, what we are seeing in terms of projections. So Dr. Belknap and I are here tonight to share a little bit of that information with you, and I'm very happy to have you joining us for another year as our CMO, Bob. Let's go to the next slide. So just a few small topics. Talk a little bit about kind of the historical, chronic, and increasing resource challenges that we're seeing, some recent snapshots and projections that give us kind of a moment in time and a look forward, what some of the workforce drivers and stressors are that we're seeing, some of the insights that come out of this research, and then a little bit about some current efforts towards building towards a solution. So, this obviously BCPH's recovery plan post-pandemic is nicely tied into some of these conversations. We are going into a strategic planning year, and it just seems like the right moment to take a breath, take a pause, think carefully about, what have we learned in this emergency response of the pandemic that can tell us about what our future workforce needs are going to be. At the same time, there is kind of this ongoing national conversation that's getting picked up again around what the workforce, the public health workforce of the future needs to look like. And so those conversations are happening at national levels, they're happening at state level, even as we talk about them inside BCPH. So I will go ahead and turn it over to Bob for the first few sections.
Yeah, thanks. So to begin with, I think maybe comes as no surprise, this is not a new challenge. And so the public health workforce was changing, and there were challenges even prior to the pandemic. And so looking over the last 40 years, you can see there were, in the US, on average, 220 public health workers per 100,000 population. It decreased to 158 and to 147 by the time we reached 2020. Just looking at sort of one area of funding, preparedness dollars had decreased from 2002 to 2019 by roughly a third, and was down to $2 per capita for persons living in the US. Next slide. And so the Beaumont and PHNCI looked into this and published a research brief just about a year ago now, and estimated what the current staffing is and what the gaps are and the needs. And they published this in a report and broke it down by population served. And so you can see circled, highlighted there was the where Boulder County would fall. And you can see there's a gap. So that really nationally, the public health workforce needs to increase by about 80%. This is to meet the foundational FTEs. So really to provide what are considered the core public health services. How this translates to Boulder County would be approximately 84 additional FTEs based on their assessment. Next slide. So an additional challenge has been the inadequate and unpredictable funding. Pre-COVID, Colorado public health funding was 0.5% of the state budget, and the local per capita contribution about $1.50 per person. And it's left local public health agencies in the place to search for and compete against one another. And this, just the graph below just shows you tobacco funding for the state and how it changed year to year from 2001 through 2020. And it's really hard to staff and plan and implement strategies to address important health issues when funding is this unpredictable.
Sorry, can I ask a question about the ginormous increase in 2013? Is that due to an increased tax rate, not an increase in use of tobacco products? Is that right?
Right. This is funding for the tobacco.
Tax rate went up that year?
Yeah.
Okay.
I think that was exactly.
May have been a combination of taxes and settlements.
Okay.
Yeah. Next slide. And so what we've experienced time and again with public health is the temporary emergency funding fire hose that is transient, reactive, and inflexible. And so you can see over time, it was West Nile virus in 2001, it was H1N1 in 2009, Ebola in 2016, COVID up through this year, and then funding for Marshall fires, funding for monkeypox, and a lesson that we maybe relearned but haven't figured out how to overcome is that inflexibility. So the inability to use some of the COVID funding to respond to a current crisis via the redeployment of staff and the shifting of some resources is a major barrier. And so some potential solutions and needs are increases to the state general fund allocation, the opportunity to demonstrate ongoing need, and a necessary built-in flexibility to be able to move resources more quickly than we have now. Next slide. So just again, a bit of a snapshot. So the estimated deficit for the U.S. is about 250,000 public health workers. Concerning is that about 1 in 3 staff are considering leaving in the next year, and about 1 in 2 in the next 5 years. A big driver of this is aging workforce that's reaching retirement age. And this is likely to affect Boulder County. There are about 30 BCPH staff who are at or near the 20-year service mark for the Colorado para. And so when they reach that and are eligible for retirement, may choose to do that. And then there's regional competition for staff. So where there was regionalization and Tri-County existed for decades, and the economies of scale that brought, now they are, the individual counties are setting up separate health departments, and that's leading to a competition for staff across the metro area. Next slide. I think this is, turn this back over.
Right, so we've talked a little bit about kind of the national context, a little bit about projections. When we get down to the question of what's driving folks out of public health, sometimes there are push factors that are pushing people out of a space. Sometimes there are pull factors that are pulling people into new spaces. What we're really seeing in terms of those push factors for public health right now, and this is data that generally mirrors what we're seeing with our staffing surveys inside BCPH, are having to do with pay, work overload and burnout, lack of opportunities for advancement, stress, and the organizational climate and culture. Mental health is a really big stressor for folks. In a national survey, 56% of the workforce reported at least one PTSD symptom, and 20% of the workforce reported that their health was in fair or poor mental health. And so that's along a 4-scale range of poor, fair, good, or excellent.
And Lexi, can I ask a question about that statistic? Do we know if that's consistent with a national? Because we're also hearing
that is national.
So that's not just public health. That is meaning the workforce writ large. Because this is an issue impacting, I think, many employers, not just the public.
I have not seen the statistics for the broader workforce.
It'd be interesting to compare to see if this is higher, equal. I assume it's likely not lower.
Right. Yeah, that's a good question, and I will check into that. In terms of BCPH, we've got a couple of extra things going on. We've had multiple emergencies without being able to give our staff sufficient respite. There have been frustrations with our systems and processes as we continue to rebuild them and to get them into a lean, efficient, and effective space. There have been leadership transitions, which create staffing transitions. And we do have a need for competitive salaries. I think that probably shouldn't be under BCPH specific, but we do know that the cost of living, of course, in Boulder County is particularly high and impacted when we have inflation at the levels that we do now and the dearth of affordable housing that we have in this county. So just a little bit maybe of extra need in that space. Of note, those mental health stats did not find any significant differences by the agency setting or the supervisory status. So it was across the board within agencies. Next slide, please, Jordan. So those were some of kind of what's been happening and what the snapshot is. And as we look forward, we're not looking at our stressors as likely to decrease. We're looking at them actually as likely to increase. whether it's emergency response needs in bioterrorism, whether it's mental and behavioral health, burden of disease numbers that continue to increase substantially, climate change impacts, chronic disease impacts, infectious and communicable disease increases that partially come with climate change and also for other reasons. The very visually interesting but complex visual that you see there is just a list of the pathogenic diseases that are aggravated by climatic hazards. So it's just the pathogenic diseases related to climate change, not a whole host of other impacts of climate change. But the reason that I wanted to share that was just to really underscore the scale of what climate change is setting up for us in terms of challenges looking forward. And I would say that the last piece is that as we get, more sophisticated in public health about what community change processes look like and what best practices are and where we see real shifts, those emphases on equity, policy, and community engagement do not come without their own resource needs. Those are additional resource needs. And we feel very fortunate that we are in a place where we get to be intentional about how are we going to incorporate those best practices into our work, as we also recognize that we're going to have to work to figure out how that fits into our workforce. Next slide. So, kind of taking it back to the beginning of the conversation about retention, we should definitely be investing in retention, but we also should expect that there are going to be challenges for a while. We will continue to see turnover in public health for a while. Extra pay, bonuses, recognition, those are all helpful, but they're not going to solve the problem, the retention problem. Burnout recovery takes time, and we've invested in that to some degree, but it also may not be enough. To be able to hold everyone. Sometimes folks really need to change for themselves. And that's understandable. Recognizing that our pre-pandemic workforce structures are insufficient to meet our current and future needs and are sustaining staff stress, it is incumbent upon us to take a look at how our workforce is structured and how we're going to be proactive in planning for those needs and not just reactive. Flexibility to respond to emergency situations is critical, as Dr. Belknap mentioned. It's impacted too by our baseline workforce. If we go into an emergency already understaffed, it makes it much worse. If we don't have staffing reserves that we can draw on and plans of how we can bring people in and then give people respite, it makes it worse. And if we don't have rapid funding responses, it makes it very challenging too. I will say that the state actually did what I would consider a pretty remarkably good job of pivoting when monkeypox came into play over the summer and was able to turn some funding around to LPHAs that were delivering the services within a few months, that is a pretty rapid response. But it was also, we were all really grateful and surprised that we were able to be able to work with the state that quickly in that space. And I know that they worked hard on that. And it is something that rapid funding response is something that they have in their minds, recognizing that the emergency response capabilities are hugely impacted by that ability to pivot quickly. So local responses may somewhat improve the retention challenges, but the local response alone can't overcome all of these issues. This question about workforce planning is part of this larger conversation about public health transformation and what does the new public health, what does a modernized public health department look like? So just to take a few minutes to talk about kind of the framework for that and what some of those conversations are. So this is from a CalPO document, so it's Colorado specific. It's about core public health services. I think what's interesting to note here is just kind of this list of the foundational capabilities and the foundational services of a local public health agency. So that's kind of what we are expected to be able to deliver structurally as an agency. Next slide. And at the national level, there is no dearth of proposals and thinking about what this modernized public health system ought to look like. We have documents from the Bipartisan Policy Center, from the National Network of Public Health Institutes, from Trust for America's Health. What's interesting is that there's an enormous amount of agreement in terms of that a significant investment is needed in public health workforce. There is unanimity there. Sometimes the proposals are a little bit different from each other. What we hope is that letting these thousand flowers bloom of wonderful think tanks that have really putting some time and effort into thinking about this will help to drive conversations at the federal level about what to actually do about it. So some of the common themes, next slide, please. Include workforce, but also have to do with financing. So that flexible financing and sustainable funding that we mentioned. Investments in data and information technology. There were moments during the pandemic where we wished we had a lot more databases that we could draw from at the national level, at the state level. It continues to be a space where we feel like those investments would be helpful in planning and help us to really target some of the most effective interventions. Governance and law, modernizing public health governance and law. And this is a particularly important space when we start to talk about equity, community engagement as a pathway to supporting equity, and what is public health's role in informing policy. And what we see is that the traditional governance and legal structures aren't always in sync with what those goals and what's required to advance work in those spaces is. And so really taking a close look at how do we reconcile that? How do we find, how do we thread the needle to really be able to advance public health interests in a broad sense, incorporating the recognition of the real need to focus on disproportionately impacted populations. What does it mean to do in community engagement, et cetera? That community engagement and trust, that investing in relationship building, and then of course, cross-sector partnerships are two of the final themes in that space. Okay, at the state level, the Colorado Public Health Improvement Plan really is focused on, at this point, it's focused on investing in public health with funding levels that are appropriate, flexible, and sustainable, improving workforce recruitment and retention, and increasing the performance and longitudinal tracking of the public health service delivery system. Those are the three core focus areas of the state level public health improvement plan going forward.
Who develops that plan, Lexi? Is that CalPO or what's?
CDPHE, I think, is in charge of it.
Yeah, it's CDPHE led.
Okay, and so we also have talked to you before about the workforce study that we are planning to do at our agency level. And I just wanted to share with you kind of the scope of work for that. It does include an organizational structure assessment, not just emergency response, but a broad organizational structure assessment that includes reviewing and analyzing the current distribution of roles and professions within the department and recommending adjustments to the deployment of staff within the organization congruent with being able to respond to future emergencies. So part of the trick, of course, of emergency response is that when there's not an emergency, what are people doing with their time? And when there isn't an emergency, how do you deploy them without completely disrupting their normal responsibilities? So that space, I think, is a space that a lot of public health agencies are talking about much more intentionally right now. And so we expect to be learning about what some of the other models are and what makes sense for our own agency.
Lexi, on that note, are there discussions going on about having more of like a volunteer workforce or something like that where you flex up, flex down? Sort of, I'm like thinking of the military analogy, right? Where they have people in reserves that can come out of their civilian life to potentially help support a crisis. Is that something that
Yeah.
you do currently, is being discussed?
We absolutely deploy the Medical Reserve Corps.
Yeah.
We used them to great effect during the pandemic.
Right.
I think that building on that
Yeah.
and understanding, what do we need to be able to rely on that workforce and what is the gap that they can effectively fill and that we can count on is a really important part of the
Right, and of course, the
conversation.
training component and all the things, you have to invest no matter what, right? That's really helpful. And then the other question I have is you guys, as part of this workforce study, are you looking at, it sounds like the priorities are very broad, right, for public health, like these are the things. Are we digging deeper to say programmatically, if we really have to think about flexing to potentially a more limited workforce that needs to maybe focus on quote unquote higher priority areas? Or is there any conversation going on around things that we potentially need to take off the table to enable the workforce that we have, the realities that we're living in today?
So I think part of what's opportunistic about the timing of this is that this workforce study will be happening alongside the strategic planning process. And that should help lift up some of our priorities. I will just also refer back to the some of the other aspects of the scope of work that you see in front of you. The gap, there will be a gap assessment to inform areas for growth or decrease, as well as possible areas to increase cross-training, to highlight areas where positions may be shifted to minimize drastic overhaul of positions or changes, and identify essential positions to emergency responses that are sometimes difficult to fill. So I think that's part of getting at what you're talking about. Public health staff get notoriously anxious if you start to talk about reorgs or prioritizing.
Alone there.
Prioritizing. Anybody would, right?
Yeah.
But what we're really looking for is, the long term. We're talking about a 10-year time horizon. It's not talking about trying to immediately, write up a new org chart. It's really about what is our North Star as we go forward and as we move through these processes.
Similar question then is looking, the slide that you showed first showing decreases in dollars and staff. That was over 2 decades. So is there any chance that some of that was through the creation of other departments, outsourcing to private industry as a standard? Did the department shrink because there were other players there?
It's a good question. I don't know the answer to.
Yeah, okay. And so I just, thinking ahead, there is the potential then, is the state considering creating some other department or some other entity that would fill some of these gaps?
Well, boy, I could get really philosophical with you for a while in this space because there's so many spaces where it feels like money has been pulled from public health to invest in treatment. And so instead of investing in the prevention, we invest at the end after the harm is done, and it costs much more money to pay for that. It's less efficient. You don't prevent all of the other harms that come along with the primary harm. And so, even just having that conversation about the value of prevention and particularly primary prevention and the return on investment that it provides, it hasn't historically won the day, right? It's historically lost. Public health has not historically had an enormous amount of political power. But it does feel like there is an opportunity right now to really shine a light on what happens when you don't invest. I mean, public health gets 3% of the health budget in the United States. So I think that those conversations have to keep happening, and I think that it's really incumbent upon public health leaders to have those conversations, to have them publicly, to have them often, to say, let's look at the data about what the return of an investment, for instance, in Family Connects. We know that investing in those little kids right at that moment is going to be huge. And so there may even be an opportunity to shift where the funding flows are and to recapture some of those savings for reinvestment in public health, which I would love to, hear some innovative ideas about what the funding flows look like that start to experiment with some of those spaces.
And did the state increase public health budget, LPHA's budgets at all? I mean, as part of the last legislative session when we had record revenues in the state?
So a year and a half ago, the state decided to increase per capita funding to local public health agencies for 3 years. And the first year they used ARPA funds to do it, which made it very difficult to spend because there were all kinds of handcuffs on that, restrictions about what you could spend it on. And so we have basically a little less than 2 years left with those extra per capita funds. If the state legislature doesn't do anything, then it will become permanent. But they could easily do something. They could easily decide we don't want to make this permanent before that. So I think we're kind of all in LPHAs kind of holding our breath a little bit and making sure that we are not programming the funding for something that is a long-term need that we won't be able to manage, and really thinking about how do we use this opportunity to invest really wisely with something that's going to help set us up for success 2 or 3 years down the road. And then if it does become a permanent public health budget increase, that would be wonderful.
Sorry, which legislative session will this come up? What year?
So the funding, the end of the 3 years will be in July of 2024.
Okay. And I should know this, are we preparing from a policy perspective and a legislative perspective for that fun discussion?
So CalFO actually is doing a lot of investment right now in thinking about how to advance policy priorities having to do with public health funding. That is a core part of their focus. It is part of federal conversations and maybe also part of other state conversations that are going forward.
I have another question about workforce trends, but I assume that this continues, so I can wait until the end.
I have just this slide and one more.
Great, I'll wait until the end.
All right. There is a component you had asked about, I think someone, maybe Brooke or Lindy had asked about programs, looking at program effectiveness. I think we do want to make sure that we are really maximizing achievement of our community goals within programs. What that will look like, we don't know yet. And we also know that career advancement is emerging as a critical issue for a whole host of reasons. It's not just the retention, it's not just recruitment, it's also about morale, it's about mental health, it's about excitement about coming to work, it's about keeping our workforce engaged. And it's also about making sure that as we move through these transitions that we have stability within our agency. The final piece of the workforce study has to do with compensation and a pay equity analysis, just to make sure that our salaries are in alignment with where they should be. Next slide. So I do not expect you to read this whole slide. You will get the slides afterwards as per usual, but what I really wanted to show you was that this is an example of 4 areas: supporting and retraining the workforce, building and evolving capability needs, innovating to flexibly extend workforce, and creating robust talent pipelines. 4 areas where they have looked at kind of the traditional model of how do you plan in this space and thought carefully about what does this future landscape tell us about a different way of thinking about this issue and things that we would want to incorporate. The final column on the page is just a reminder that we have already started working in some of these areas, and it's nicely aligned with that kind of vision about the future public health workforce. And there is that kind of, just right at the end, that cross-cutting issue of cross-training staff and creating cohorts for strategic priorities, active mentoring and coaching. It ties into career advancement. It ties into emergency response. It ties into a whole lot of different kinds of issues, and just keeping that one in mind as a cross-cutter. And that is our presentation. We have a few, one more slide, please, Jordan. A few questions for you all for discussion or to answer any questions that you have for us.
I had a question. So you laid out about how many public health workers are planning to retire or leave public health. Do we know anything about incoming public health trends, workforce trends? And for instance, did the pandemic inspire people to join the public health workforce? Maybe at the beginning, maybe less so as it wore on. But, you know, when I was in public health school, like almost 20 years ago, we were out there talking to high school kids, explaining what public health was. Now it feels like there's a lot more understanding about public health. So I'm just wondering if we know anything about national trends in terms of young people going in.
I haven't seen data. I've only heard anecdotes, and some of the anecdotes suggest that there are people that are seeking out careers in public health, and even some of our rural counties at the recent CalFO retreat were commenting that they are getting more applicants for positions than they had in the past. So those are certainly positive and encouraging signs. And so I think there is an opportunity. That pipeline, I think, is going to take time.
Mm-hmm.
Confidence is going to take time to catch up probably to the turnover we're likely to see in the next year or two. But yeah, I think there is an opportunity because there is an awareness that didn't exist 3 years ago.
Right.
And so capitalizing on that and harnessing that, and that means having those positions, building the infrastructure and having the funding to have positions to be able to bring on new talented people while promoting people who've been working in it. So, the timing, while it's going to be challenging, I think for the next several years, I think if done well, we could be in a much better place in the future. All of it ultimately hinges on, is there support for funding these activities or not? Because
Right.
if that trend of 40 years of public health workforce to population continued, if we said, all right, the funding from these acute emergency events goes away and we go back to how we were before the pandemic, it doesn't matter how many people enter that, we're not going to be able to employ them coming out. So
I agree. It's definitely a longer term structural issue. I am seeing some creative bridging opportunities in the meantime. AmeriCorps has created a public health alongside their teaching cohort, which is great. We're seeing a lot of folks come in through there. I think when I asked Amanda about this, I think we had hired something like 20 volunteers and interns. So not short term, but at least like 9 months to a year over the last couple of months. And we have another, I think, 15 in process. So that's great. It's going to take us some intentionality to make sure that we can actually support them as they're here. But it's wonderful to see the enthusiasm for folks to step into this space.
Yeah, that's what I was going to ask you. I know, I went to the School of Public Health at University of Michigan, and I get requests every year for internships, right, which are sometimes can be free, right? And so people really want a solid experience in their summer, and I know that's, like you said, a lot of support, but it is pipeline building and then engaging with these schools to really help recruit people right out of school. But it sounds like you're doing some of that already, but obviously I wanted to offer my alma mater as an opportunity directly to support. But I think there's a lot of students out there that would really like to get that experience. So,
well, and they love to come to Boulder too.
yeah, well, and that's the other thing I was gonna say. If there's a draw, there's also like the headwinds though that you described are so real too in terms of the cost of living in Boulder. Mm-hmm. So I think, yeah, it's a great place for people to want to come to live, but then can they actually afford living here is the question, so.
With the attrition question, is that mostly retirements? And then where are the people that aren't retiring? Where do they go? 'Cause I'm just curious, is this a situation where we're growing a consulting style culture where people are leaving, going to companies where they can serve multiple public health departments and make more money? Like where do they tend to go after?
I think it's a mix. I think we would need to look specifically at our departures at BCPH, but I mean, I know folks who are found a better match for the work that they're interested in other public health departments. I know folks who have moved between public health and another county department. Some folks have retired. It's a mix. To get you anything specific in terms of weighting, I would have to take a closer look.
I was just curious.
Yeah. Yeah, because we've had a lot of attrition in SIB, right? The strategic initiatives. And I think most of those people found other positions, right, that were maybe less stressful, paid them more. And we lost some really good staff because they just couldn't afford to live here anymore. And they could work for another LPHA someplace else where the cost of living was half of what it is here, for example. And I think that's a huge elephant in this room, frankly, right? It is really hard. We've been recruiting staff. We have several positions that we're recruiting like 2, 3, 4 times because we can't get people and to take on those positions because of the, for us to live here is going to cost this amount of money, or, the salary we offer is that. And they're like, I'm sorry, it's just not working for us or whatever. And we do get a lot of people that are just coming out of university and public health schools and things like that. But I think, that's something that I feel we're going to have to live with and try to figure out how to get around that creatively. But I think that's part of our planning process when we look at, we look at the next year in 2023 of looking at this workforce discussion and looking at our broader strategic plan, because 2023, as you mentioned a couple of meetings ago, is really focused on planning and how do we implement priorities? What does that look like? And so connecting that, as Lexi said, with the staffing and workforce study, I think will be really critical. And then that all feeds back into our budget, which we were talking about earlier. So all these pieces getting interconnected along the way.
I mean, what percentage of Boulder County employees live in Boulder County? I think it's less than half, right? I mean, I don't know what the recent numbers are, but I don't think it's, again, a public health issue.
No, you're
right.
absolutely
But it's
right.
just,
But it's not even just a Boulder issue or an expensive
yeah.
place to live issue. Cheap cities can't staff
uh-huh.
things either. There's something bizarre happening and no one can quite say exactly what it is. So even with higher salaries, you may still have the same staffing issues that everybody else is having.
And and as I say, it's like, I think there was one slide in there that was like, we're gonna do these tweaks and these retention strategies and and I think we're still gonna see some turnover for a while.
I think you will.
Yeah, I agree. There's something mysterious that's going on top of all these headwinds that is, you can throw a lot at it and still not attract talent. It's fascinating. So interesting times.
For the pay equity analysis, is that mostly within the department itself, where you look at like classifications, you look at experience, you look at education, you kind of come up with some composite score and you say, here's the spread of, because I could think of like, certainly before the pandemic, but even since the pandemic, you're bringing in people who may be less experienced in their career at higher salaries because that's what the market's requiring. But yet somebody who's been here 15 or 20 years with their normal kind of merit growth, that's gotten eroded over time. And so that span isn't as big, which, I guess there can be positives and negatives to that. But I'm just curious, like for that pay equity analysis? I mean, I know there's the compensation side, right? Which may look at a whole bunch of other macro factors, and the state, but is that limited, or is that pay equity analysis throughout the county?
So we see several spaces where we would like more clarity on this particular issue. One is internal, because we do still see differences across divisions in particular, or particular roles that feel like they may not be quite aligned. We also know that I do have to do some kudos to the county who implemented a pay band structure in the last year where similar classifications were grouped across county departments and they were within the same pay band. And what that did was it created a structure and a uniformity of understanding what we're trying to compare to each other. And so there may be slight tweaks, actually this classification has much bigger responsibilities than the group that it's in with, maybe a little shift there, those kinds of things. But mostly what we want to make sure is that, our folks who work in policy are in the same pay band as the county's folks who work in, or whatever the example is, right? The third piece really is more about that compensation and involves kind of a market analysis. And the good news is that at the same time we're doing this analysis, CalFO is running a compensation analysis. So they're going to be collecting a lot of the data for us that we'll be able to use. And, try to just get a little bit closer to uniformity. But you're exactly right, Greg. That is something that we've seen is that, the desperation of the hiring, the labor market right now is changing the way that offers come through, and it creates its own ripple effects of inequity within the agency. Yeah. And I think everybody's seeing that right now. Not unique.
Yeah, I mean, the only other thing I wanted to say is just that, when I'm going back to what Catherine was saying, and so I think this would probably be better discussion for the budget study session, but in terms of wherever pay equity or wherever compensation levels end up, is not treating differently. I mean, I know it's really hard, right? When you have somebody who's fully grant funded, you built that grant with a budget, assuming certain factors, but then county funded staff would benefit from compensation or pay equity increases, but the grant funded, is there a potential that is going to happen?
I would like to say no. We have a stronger commitment to equity within our staffing than that. What the solutions are in particular situations may vary, but it is absolutely something that is on the radar. We do not feel like it's appropriate to, for instance, give raises to compensate for an increased cost of living to some of our staff and not give it to others. There are interesting philosophical questions too about whether you award increases based on percent of salary or a flat rate, which is a much more progressive way of, kind of reducing inequities vertically and structurally within the agency. And those are conversations we haven't had yet.
Okay.
I really appreciate you guys staying focused on this topic. I think as I think about what I'm worrying the most about, this is probably it fundamentally, because we're not doing the work. We're helping to support the work you guys do. And you need staff to do it, and you need experts to support that work. So anyway, I really appreciate it. Thank you for keeping this at the fore.
Absolutely. Thank you very much, Bob.
Yep. Thank you, Val. All right. Are we good on that item? Okay.
Yeah.
All right. Item 5, program spotlight, vector control.
So thanks. We are trying to have a particular program spotlight every month, just to provide that opportunity to do a deeper dive, really learn, who our folks are, a little bit of the nitty gritty without getting too much into the weeds. Vector control is in Joe Malinowski's Environmental Health Division, and I believe Lane Drager is with us this evening as the coordinator of vector control, among many other roles. Thank you for being with us tonight, Lane.
Thank you. Thanks for having me. So Lane Drager, for those, any board members I haven't met, and those that I do, good to see you again, twice in the same week. That's awesome. I coordinate several programs, but I'm going to talk about two programs. The first one we're going to talk about actually is our mosquito control district. So this is maybe a little bit of a unique program in public health. I won't go through all the history, but the origins of mosquito control work are a seasonal technician that you may recall by the name of Jeff Zayak, who was with public health for a long time. So, but we administer the mosquito control district on behalf of the commissioners. And so the origins of the district really go back to just really nuisance control. But when I started in 2004, that was our second year of West Nile virus. So the mosquito control district has played a pretty critical disease control role for some time. And so the structure and funding for the mosquito control district is through a property tax assessment. So every 4 years we do a calculation, we create a budget looking at our staffing costs, the bulk of the money going to the contractor we hire to do the work. And so that's really where the funding comes for that program. So we build out that budget and then create a tax assessment. And so again, something we should definitely look at as we look at from this last topic that you just talked about is creating those fundable, sustainable funding sources for specific issues, even though we would like to see sustainable funding for all public health. But I don't know if I can move slides or Jordan.
You can just say next slide and I'll move it.
Yeah, please, next slide. This is just a quick picture of where our district boundary is for the mosquito control district. So that light blue color, all the municipalities, at least in the Plains area of the county, have their own individual mosquito control programs that we work very closely with them. Outside of the city of Boulder, we have the same contractor. So that also makes it pretty easy for our coordination efforts. Next slide, please. So we really focus on integrated pest management. So that is really the focus of what we do. Certainly, probably the most controversial part is the adult control, but that is honestly the smallest component of what we do in our program. Next slide, please. So larval control is the main focus of what we do. So we have historic mapping of where our mosquitoes are breeding within the county, and then the contractor employs field technicians that go out and do that larval control assessment, and then where appropriate do treatment. So this is definitely also the most environmentally friendly way to control mosquitoes, in addition to the most effective way. Next slide, please. We do adult surveillance, so this is looking both at populations. In addition to that, we do our West Nile virus Sentinel surveillance. So we have a series of traps, as do the municipalities, and we all share that data, and it helps inform any additional control measures we might take. Next slide, please. So for West Nile virus surveillance, this has changed over the years, as Joe can recall too, when and honestly back to the previous conversation. So West Nile virus had a lot of funding when it was hitting the United States. We had a lot of ability to do surveillance across the county. That money has not completely dried up, but mostly dried up. So then we, in the state, created the idea of Sentinel surveillance zones. So we have 3 zones that are hitting the majority of our population areas, where we're doing testing of our adult surveillance traps to detect West Nile, and then calculating infection rates and vector index, which give us relative risks within our community for us to potentially take additional control measures and make additional recommendations. Next slide, please. And adult control, so obviously people seeing fogging, that's the most controversial. That's done largely based on our surveillance date. We aren't just doing prescribed, we always spray this neighborhood every day of a week. It's really looking at what are the populations telling us. And certainly for disease control. We're looking specifically at speciating those mosquitoes that we catch and really looking for a higher risk for West Nile virus, and those are then the drivers. But again, the origin of this district was for nuisance control. So that's still a component that we've done surveys every so many years just to assess the continued desire of the unincorporated county to have a program that still addresses nuisance control. That being said, we have really focused on finding a balance of when we do that so that we are conscientious of using pesticides, even though the pesticides we use are fairly benign in the environment. Next slide. So I wanted to show you just some data, kind of see where we're at this year compared to some of our historic numbers. So kind of in the last 5 years, this was definitely a bad year. And these are our total populations. You can see that purple underlying graph is that 5-year historic average. But that being said, the last few years, we've had some higher numbers. So the next slide, I think, will show you compared to more a 10-year average. And you'll see that the underlying, if you can do the next slide, that huge drop between where those numbers were the previous slide to this slide. So, significant numbers, and this is just total mosquitoes. So this is driving both our nuisance control. And then the next one is going to just focus on our Culex species. And so we have 2 specific species that we look at, but these are the ones that drive more of the human disease. So here's our 5-year average. You can see again, this last year minus, a few months, we were significantly beyond our average. And then when we look really across a 10-year, again, you can just see how much that dropped, over 3,000, kind of from those peaks of the different shading. So significant risk that we've seen with Culex, and this year, the human disease is definitely bearing that out. So we are certainly not out of finding what our final total of human cases will be, but if you go to the next slide, and actually I may have lumped some of our human disease into our overall vector numbers. So I'm going to just do a quick pause if there's any kind of mosquito before I jump into some of the other vector related stuff that we do, which is under our public health purview. But any questions on that? Again, this is kind of a unique district program that the health department has historically been the financial agent for, and then we have staff working in it.
Lane, I have a question. I'm not sure what species are present in Boulder County. Have you seen any shifts in the species that are present over that time?
No, we really are conscientious, so not to get too technical with you, but the mosquitoes that are of concern for some diseases that we don't deal with, we do not have. So when we think of Aedes albopictus and so mosquitoes that drive things like dengue and some of these other diseases that are more tropical diseases, we do not have those. So that is still something on our radar as we talk about climate change and changes in our climate. If we become more humid, that is something that is a potential. There are other diseases that we don't have in our country that mosquitoes we do have in Boulder County and in Colorado could carry. So that's another concern similar to West Nile virus, which didn't exist in the US until '99, and then within 4 years, it was in Colorado. So again, it wouldn't take a lot if you introduced another disease into our country for it to just be rampant and then very present. So our main nuisance species, the Aedes vexin, is a disease-carrying mosquito in other parts of the world. So again, not gloom and doom, but it is something that we're very concerned about. Again, how vector diseases move around the world. That's probably one of the greatest risks for climate change is vector diseases, first of all, that are present, and then the potential for emerging other vector diseases. So we do not have mosquitoes for dengue and some of those other diseases, malaria and things like that.
Elaine, this is Lindy. I was under the impression the data you're showing is human data, for lack of a better way to say it. Are we tracking animal data as well to understand, are the trends pretty similar this year in 22 that you saw in humans?
Yeah, and I just lumped all of our other kind of disease stuff into my next set of slides, but our human cases this year are much higher than they've been for the last several years.
Yep.
I think we are at currently around 35 human cases, whereas we were, I think, 18 or 19 last year. So still smaller numbers overall of, overall burden of disease. But we also know that for the most part, the disease that we are tracking currently compared to what we tracked when West Nile first arrived in our state is the most neuroinvasive cases. So those milder fever cases, we aren't even really getting reported anymore. Just the level of work it takes to identify a case is something that most healthcare providers are not doing because there's no treatment they can give even for neuroinvasive cases. So to do more invasive testing for a disease that they can't do anything to cure, it just doesn't happen. It's similar to several of my programs like foodborne illness. It's like you're just going to have to wait for this to resolve, so we're not even going to test you. And that's even personal experience from a recent trip to Mexico. Nobody was willing to test because of the cost versus what they were going to do. So.
Lane, one other question. Oh, sorry. Go
That's
ahead,
okay.
Morgan.
No, it's okay, bro.
It had been mentioned at some point kind of randomly in one of our meetings about potentially needing to lengthen the period of mosquito control. It was just sort of offhanded, but it doesn't look like that's happening right now.
It is actually. So,
Oh, it is.
So just in my tenure, even in this position, I've seen a significant change in our seasonality. We used to always just bank on, we were done in August. The end of August was for sure the end of our season. We were fortunate, even in the 2013 flood, that it could have been worse then, that the flood occurred in September, but it still there was impact there. We actually stopped surveillance because the state was no longer testing. We pushed them to test for another week, but we just stopped testing in the middle of September, and we were not out of the woods for risk. So the seasonality has definitely shifted. We plan now to go well into September, even potentially through the end of September if necessary. We haven't had to go that far yet, but yes, the seasonality is definitely shifting already with warmer climates. So those are not future things, they're current things. And so that is a big concern, is if we start to see our season go longer and longer, we will certainly see more human disease. We will not eradicate West Nile. That's not even the goal of the district program, is to eradicate mosquitoes. It's really to manage them to a controllable, certainly for nuisance. And then when we're looking at human risk, do our best to manage that. But eradication of mosquitoes is not even possible, really.
Thank you.
Lane, I know you said you coordinate with the municipalities that are not within the district. Do all the municipalities follow the same interventions that the district does, that BCPH does?
No, I would say most do. We're all fairly similar. The city of Boulder is pretty unique. They do have some larval control still, and there's a little bit different protocol that they use for when they decide to initiate that, but they do not do any adult control. They are doing some additional West Nile virus surveillance though, so their focus then is just educational approach as there's risk. But yeah, that has been, I think the bigger challenge with their program is that the significant amount of land that they own, the open space land that the city owns, that is often flood irrigated and creates a lot of habitat, and oftentimes adjacent to gun barrels are the best example where we have county residents. So our only recourse then is to do adult spraying because we have no ability to do any larval control on city open space or city land of any kind. So we've really worked as much as we can, but our programs have a pretty significant philosophical difference.
Has that been based on like surveys of the populace of the city of Boulder? Or, I mean, is it just
I can't speak to that. I know their open space board is very supportive of the direction that the city has gone. But yeah, for at least for the mosquito side, they're very anti-using anything, including even larval control. So it's still something that they're making specific decisions when and where they want to do that based on, you know, their assessments of their different habitats, of when they feel it's too sensitive to do anything to.
Well, please give thanks. I'm somebody who's also interested in mosquitoes. You know, to Marshall Lips and his zoonosis report. I like those every week. That's pretty good stuff.
Thank you. That's very good here. And Marshall is the engine behind all this. He does the work with our contractor. For those of you who haven't met him, prior to hiring him, he worked for the mosquito control contractor that we employed. So he has intimate knowledge, and he really managed the Boulder County program. So he walked in the door with all the knowledge he needed to help really administer it. And now he does all sorts of other programs besides mosquito control. All right, well, we'll jump into vector, and I'll kind of breeze through this. Go ahead and advance to the next slide. The major diseases that we kind of look at under our vector control program are plague and tularemia, and they're very sporadic on when we see those pop up. We already talked a fair bit about West Nile virus. Rabies is our biggest disease of investigation, and hantavirus we seldom see, but we have had cases over my tenure. And each one of these, so our vector-borne program is looking at things, the animals and insects that transmit disease to humans. So largely these are insect-based. Rabies is mammal-based. Next slide, please. So plague, really spread by fleas, can get to pets if they were to eat an infected animal that had died of plague, but also fleas a risk to our pets. And so that fact that pets can get plague, predominantly cats, not as much dogs, that's a risk obviously for the pet owners. Next slide, please. Here's just some of the common ones that we see that carry plague, but it's mostly rodents and lagomorphs or rabbits. Next slide, please. Tularemia, so these are, again, fairly rare human diseases, more things that are impacting wildlife and then spill over into our pets. Tularemia is a tick-based disease. Occasionally deer flies, more of a risk for ticks, I think, for us here. Next slide, please. It's also kind of most common with rabbits, kind of commonly known for hunters as rabbit fever, but it can be, again, in sort of all sorts of different rodents and small mammals. Again, when we see this, we don't see this a lot, but when we looked back really over the last 30, 40 years in Colorado, there are cycles where we see significant tularemia kind of presence, you know, and that happened several years ago where we were seeing it, even just sort of environmental exposure. There was no clear exposure to ticks. And so the concern is that it becomes so prevalent in the environment that even sort of mowing and things like that can potentially cause a risk. We had an infant who had no exposure that got tularemia. And since it's such a rare disease, it's often not diagnosed. So that's, again, one of the risks with it. Next slide, please. West Nile, again, this is a bird disease that really spills over into humans. So that's just the reality of it. And we do have plenty of birds that are part of that cycle. Next slide. So there's several of the different species that are present. Next slide. Rabies is our most significant vector disease where we spend the bulk of our resources, as does our communicable disease. So this is really from a bite or saliva transmission. So in some cases, a scratch is still considered a risk. Next slide, please. These are our main priority areas. You know, we're looking at that on the EH side, the pet component. We then work very hand in hand with our communicable disease team to look at then the human exposure. But bats and skunks are our primary reservoir concerns, raccoons and some of the other. Throughout the state, there's been mountain lions, there's been all sorts of different things, mule deer and deer and So we've seen it definitely still spill into, but rabies and skunks are our two primary concerns. Next slide, please. Hantavirus, very rare here. It's not all mice, it's specifically the deer mice. And then there are some other rats that are involved. This one is often more in rural areas, cabins and things that are not used all the time. And so they get an infestation and people come in and clean and aerosolize the virus and then inhale it. And it has a fairly high fatality rates. So it's definitely a concern when it's present. Again, we've only seen a handful of cases during my tenure, so it's not something we see too much here. Next slide. There's their species that are more prominently of concern. Next slide. All right, let's get into some numbers for you. So we've had 109 rabies samples submitted, just to give you a comparison to last year, which was a quiet year. We had 95 samples, but the big thing is the investigations, and I don't know that I can see my notes, so let me just pop over. I have some other notes over here to give you that frame of reference. So the 208 investigations that prompted not everyone is a sample sent in. That is a significant number. We have not seen anywhere near that kind of numbers in the last few years. So last year was a quiet year, so we only had 80, I think, or so overall investigations, 91 in 2020, which was definitely a tougher year to compare because we really didn't have a lot of staff, but we certainly were not getting a lot of reports of anything because I think people were just not reporting that much of anything outside of COVID. And then in 2019, we had 114 investigations. So a huge jump this year. It's been an incredibly active year for us. And then each one of the investigations may or may not involve our communicable disease folks too. I don't have a good breakdown for how many human investigations they have, but I know we've had a big number. I can even pull that up for you. The number of human pet. I know we have that.
Lane, an investigation is triggered by somebody calling BCPH and saying, I think I saw a skunk acting weird or a raccoon acting weird.
Possibly that's one way. We often get it more. So our biggest partner in this program is our animal control. So they are the ones who are going to often respond. So someone sees a weird acting animal or one that has gotten a fight with their pet. Often animal control is the first point of contact. So then they are the ones who are working with us. They're bringing specimens in, and a decapitation occurs typically by them or by our contract vets. And then we're sending that specimen in for testing. Bats, we send the whole bat in. But again, not everything will initiate a specimen. If there's really no risk, someone sees a weird acting animal, no person or pet has interacted with it, there's no reason for us to send that in for testing. Potentially animal control might euthanize it if there's a risk within the community, but there's no reason to test. Even finding a bat, in your garage that's desiccated, again, there's no risk of exposure there, so there's no reason to test. So, and then in some cases, there's multiple tests for one investigation where, hey, they found 3 bats and they don't know which one was in the room when people were sleeping or something like that. So sometimes we have multiple samples for one investigation. But let me get that. So for human, we had 30 individuals and families where post-exposure rabies prophylaxis was recommended. So of those 200 or so investigations, again, most often we see animal exposures, but we had at least 30 different cases where families or individuals needed to have that recommendation made. On the pet side, we saw, let's see, so we have different, go ahead. Is there a question? Sorry.
No.
Oh, sorry. So for pets, depending on their vaccination status, that increases the risk of those exposures. So we had some sort of lower risk exposures where there were vaccinated pets. We had 15 cats and 77 dogs where we had to do some home observations for 45 days. We had 5 cats where they had to do a 120-day quarantine. And then we had a situation where we had to do a 180-day quarantine for 5 cats. And then we often see cats are not vaccinated compared to dogs, but there is a requirement within the county as well as the municipalities for, actually it includes ferrets too as pets. And then I think I had I had the positives there for you. Sorry, if you just go back one on the rabies. So, and then we've had very minimal plague of tularemia activity this year. I wish I could tell you what it takes to have a good or bad year. Usually we see if it's a wetter spring, that has a potential to be more problematic plague and tularemia, which this year kind of was. But we did not have that, and we're thankful for it. So, and then nothing for hantavirus this year. We rarely see much, and this is more on the communicable disease side. They do see some other tick diseases like relapsing fever and things, but those are still pretty rare. Rocky Mountain spotted fever, not really a disease we deal with so much here. Next slide, please.
What about Lyme's disease?
Lyme disease, we don't really see. It is on our radar because it is the biggest vector disease in the US, and its geographic region has been spreading incredibly rapidly west. But as of right now, we're I think dry enough that we're just not seeing it. So, but it is a concern, and we've had anecdotal reports of pets and things like that. So, but we haven't had any confirmed human acquired case in Colorado. So there's kind of a little summary through pretty much the end of our surveillance season on our West Nile virus pools. Last year was also a pretty challenging year for mosquitoes, and I showed you already some of those historical numbers compared to this year, but this was, in my entire history working here, the most positives I've seen outside of when we were testing all of our pools. But since we've had the Sentinel surveillance program, we've never seen as many positives as we've seen this year. And again, can't really explain why that is. You can see the human cases thus far and I think that number might even still be low. I thought I saw an even higher number more recently, but that was as of our last zoonotic report 2 weeks ago. But Boulder County, Larimer County, Weld County on the Front Range are the main human centers, and then on the western slope, Mesa, Montrose, Delta counties. And if you were to map the state flood irrigation, you're going to see a direct overlap of where the primary flood irrigation in Colorado is and the primary West Nile virus human disease is. So that is our huge driver. And I think that might be the last slide. Go ahead. Oh no. So here's kind of that, at least for the West Nile, you can see kind of where the predominant human cases are. And these are also our populated areas. So that's also what you would expect and where more surveillance is being done. But still at this point, it's really neuroinvasive cases. So it is people who are pretty sick that's being identified rather than just people who are feeling ill during the summer and getting tested. Next slide. So any questions? And I guess the last thing before that is just this is definitely a challenging program. I actually was exchanging earlier with Catherine about, she's like, kind of, where's the funding for this program? And there really is no funding for this program. We have some staff funding, we have some county funding for most of the staff in this, and there's no other funding. So we really run in deficit to do, the vet decapitation contracts we run, the couriers to get samples down to the state lab. There's no funding source to really pay for any of that stuff. So it all comes out of just general money or surplus within our division to cover it. So, and it's a very bare bones staffing. So we have Carol McInnes is our primary. She's a 0.6 FTE to work across all the vector diseases. And then Marshall Lips is back up at 0.1 FTE. And then on the communicable disease side, it's just one of the many diseases that they have to deal with. And this was a very active year for investigations, and they can take a lot of time to actually identify, was there a real exposure risk or not, to interview all the different family members and hopefully get the true story. So this definitely is a challenging program. And we're just so fortunate that we have an amazing partnership with our animal control staff, because if that workload came back to public health in any way, there's no way we could handle all of that. And then we have great veterinary assistants, and so we have some contracts that we pay them for some of that service. We do a lot of education early in the year. We have a annual zoo kickoff where we invite the animal control, the state health department folks. We have Colorado Parks and Wildlife, federal folks even, that come in, and we kind of have speakers and share information and just get everyone ready for what's going on, if there's been any policy changes. And again, I think that's been one of the reasons we've been successful. Certainly vaccination has addressed a lot of the risk for pets, but we want to stay rabies free in our human population. It's not often to see a human case, but if someone gets rabies, it's fatal. There's really only been a few historic cases where someone survived rabies without getting post-exposure prophylaxis. Any questions I can answer?
So Lane, the district gets funded through a slice of property tax, is that right?
Correct.
And that only funds the contractor services and not staff?
It funds, so the half of Marshall's FTE is funded out of the Mosquito Control District.
Oh, okay.
And then we also hire a seasonal quality assurance person that goes out and really is assessing the efforts that the contractor is doing on their larval control. So that also is funded out of the district. I rolled our West Nile virus surveillance into the district, so that now is being funded out of the district. And then we have a minimal operating budget also for the mosquito district that's funded by that tax. But no other zoonotic diseases are being funded out of that. That was not what the district was formed for.
So,
I know,
It's extremely troubling to me. Like, I don't. I think if the
story of public
residents of
health.
the county understood that,
I know.
it's. How do we, what do we need to do to fix that?
Well,
I mean, I
don't-
constantly think about public health prevents so many expenses for insurance providers too, like the cost of treating someone with rabies or any of that, but like all public health, right? I mean, why don't we get more money from the private sector?
Yeah.
Larger philosophical.
Yeah.
I don't think our story is unique in public health. I think
Yeah.
our story is a common story in public health. But yes, you're right. The expenses that we've seen for someone that has to get post-exposure prophylaxis is incredibly expensive. The first doses of the immunoglobulin are always administered at the ER. So that's an incredible expense on top of just the shots themselves. And then it's a series of shots. So it can get into the thousands of dollars very quickly. And we've had folks that do not have health care and do not have ability. And so then that becomes a burden sort of on the healthcare system, because these people have to get treatment. It'll be fatal if they don't. So yeah, it's a huge challenge. And then people who don't vaccinate their pets, that puts a challenge where pets, we've had situations where pets have to be euthanized because people, it's that question of, is it humane to put a pet in strict quarantine for 180 days, to really make sure that they aren't going to develop rabies. So, that especially, and it's often puppies, because that's who isn't vaccinated the most often, because maybe they're not even old enough to be vaccinated. So it's really unfortunate. And they're really difficult situations for our staff to be in the middle of too.
Are these some of the budget trade-off decisions that we'll be talking about with you guys in terms of if there's a finite pot of resources, where do we need to be prioritizing those resources? I mean, the vector control feels pretty critical from a public health perspective. So, yeah, I don't know if this is the context for some of these discussions or not, but it very much worries me that this is an issue that is clearly under-resourced and is so clearly a public health need from the community.
So one of the great things about the last couple months is that Catherine and I have learned so much about our budget and public health and how the financial structure is arranged. And, there are a lot of things that we will not be able to address by the time we come back for budget study session next month. But we are planning to be very intentional about looking across the agency at how the funding flows work. Even as we look at strategic planning, as we look at the workforce study results and things like that. So, yes.
I figured as much. I just wanted to confirm.
One other question, how does Boulder City's part of the county, how do they get to avoid vector control?
So vector control, just to be clear, is different than the mosquito control. They're all programs under me, but that's why I try to call mosquito out separately, because it is a function that we do for the commissioners. They're the overseer of the district. For vector control, rabies, again, we have fantastic relationship with animal control in the city of Boulder. They are incredibly active. They're participate in our kickoffs, knowledgeable folks. They make sure that their new folks are well trained, and definitely send those to our annual kickoff. We see a lot of specimens come in for the city of Boulder. So we have a great relationship with them, and they're very active. Interestingly, they have some programs. They do prairie dog relocation in some instances. So they do actually apply pesticides for potential plague risks in those situations, and definitely more dangerous chemicals than what we use for adult mosquito control, but it's radically different applications and for different purposes. But so they are very conscious of plague. They're monitoring their prairie dog populations. And so we also work closely with them if there's any concern, if they've seen die-offs that we may need to submit specimens for. And that's same with our other open space and different parks programs across the county.
Why don't they have to comply with county mosquito control?
There's no law or ordinance or regulation. We have a district that is formed. So that's again, a tax assessment district. And then we provide those services through a contractor for unincorporated Boulder County. Each municipality has also created a program. Their program focus for the city of Boulder is different than ours. And they're looking at different larval habitats, and then they have kind of a different criteria for when they will do larval control. But again, it's each municipality is in control of what they want to do related to that.
Thank you.
Well, thank you, Lane. Appreciate
Thank
it.
you all.
Thank you.
Bet.
Vector control and tattoos. Lane is a
Multi-talented.
yes.
All right, let's see. All right, we're trying to get back to my agenda.
It's yeah, we have
Okay,
to-
item number 6, Executive Director Recruitment Firm Approval. Whose agenda item is this, ours?
This is ours. We have to vote if we want to hire.
Marine Group?
Yeah.
Okay,
Do we have to specify Marine Group?
well, they are the one who submitted to, under the RFP that we were able to use.
We have to specify them unless we want to take it back out to bid.
Okay.
I think is my understanding of
Yeah, I
it.
think that's right.
Okay, well, we discussed that in our board retreat. So, I'm good with it. Anybody have any concerns? Okay, then can I hear a motion to approve the retention of the Moraine Group to help us hire the next executive director?
I move that we retain the Moraine Group to assist in the hiring of the next executive director.
I will second.
Okay, all in favor?
Aye.
Aye. All right. There's that. Obviously, there will be more to come on upcoming board meetings about the process, but just at least for now, we have our executive recruiter. So item 7, director's report.
Great, so we are in our second month of kind of restructuring this report to you a little bit. I just highlighted a few of the sections just as a prompt. If anybody has questions, that's great. If not, also fine. No actions needed tonight, but open to talking about anything anyone wants.
I had a question on the mental and behavioral health strategy planning. Is that being done entirely internally for the county, or are you engaging private and external partners like mental health partners?
Right, so this is a really exciting space that we're getting into because I believe it's the first time that we've really been very intentional about having public health actively participating in partnership to develop a countywide strategic plan on mental and behavioral health that isn't just related to county government, but also does include those community partners.
Also, yes, quarterly retreats, that sounds good to me.
It sounds good to you, is that what you said? Okay.
But maybe not as long?
Well, that's my only concern is the time commitment. I mean, we love volunteering in this role. It's been a lot of time lately. So that's my only note about quarterly retreats is it is hard to book that much time. Every quarter is the last retreat that we did. So just thinking about how we structure those to make sure that you get, what you need out of them, but
So happy to talk more about that. I mean, I think there are some options. One is that maybe that month we don't also have a Board of Health monthly meeting. We could skip the monthly meeting that month. And we can also arrange it to be at the pace that works for you all. So just let us know what works. Again, don't have to decide right now.
Yeah, or we could, I think we could also try it out and see how it goes and.
I think the only problem is when we have 4 months in a row or something we have to vote on.
Right, yeah.
And we can't really, unless we
You could have a
the
public
meeting
meeting
for 30
as part of
minutes.
it, right? Like added on to if there was something we had to vote on. And I think that's the other thing that, our folks that like to show up every month to comment, like, are they gonna feel like they are not having their voice heard if we are not having at least some portion of a public meeting every month, so.
So just a reminder that our bylaws do not require us to meet every month.
Yeah.
I think that definitely became a habit during COVID. I don't know, maybe Kelly or Joe can speak to, was it always a month?
It was always.
It always was.
Yeah.
Yeah, we usually will skip 1 or 2 meetings a year. For whatever reason, just lack of agenda or holidays or vacations. If you're kind of calling it a retreat, then maybe quarterly is a bit much. But if it's really more about being more in tune with development and helping with implementation of strategic planning, with a new director coming on board, Maybe we should give it a try at least to see, okay, is this frequency too much or too little? Well, it won't be too little. It'll be either too much or just right.
My view is we should plan it, see how it goes.
Yeah.
If the agendas feel like I don't think we're just meeting just to meet, to get educated, like that's not, So I think particularly knowing that there's going to be a leadership transition, again, I just think we need to kind of be in more communication versus not at this stage, but and I think we're doing it, but if I don't say so myself, a great job of that right now. So, just keeping that momentum, but I appreciate balancing our lives around this volunteer commitment as well. So.
Are you guys don't get paid?
Yeah.
Yeah. Oh, can we talk about that in the budget? Jessica, that was a joke.
One other question on the WIC. I noticed that there were inflation increases for the breastfeeding needs, but not for formula. Is formula cost controlled? Just curious why that was left out of the.
Wow. That is way down in the weeds for me, Brooke. What a
Okay.
great question. Daphne, are you still on and would you like to respond to that question?
Sure, I am still on. And can you repeat the question that you asked about the formula costs?
Yeah, I noticed that it wasn't included in the interest increases that were provided for produce and breastfeeding needs. I was just curious why formula wasn't included. Is it cost controlled?
Formula is fairly cost controlled. It's set with a federal contract each year, and they have a very limited number, I think really 1 or 2 suppliers, which is part of why we got into the formula shortage. Because there was a disruption in one of the factories that created a 25% decrease in formula availability, which definitely surged a lot of stress on my team this year. But the actual financial contracts are set annually. So that's probably why. I mean, I'd have to go a little bigger than that, but that's probably why.
I think too, Daphne, when you have WIC benefits, you don't pay per can of formula. You just get what's designated to you. So you get like 13 cans. It doesn't matter the price for the person using WIC.
Got it. Thank you. I had no idea.
It is interesting though, with the formula shortage, it really did shine a light on the supplier chain related to all of this. So there's definitely some work being done at the should we have more competition? Should we have more entries and stuff like that? So there's work being done. I think approximately 50% of all babies in the US are definitely eligible for WIC, if not on WIC. So it's a big deal and something we should maybe come at a future meeting with a deeper dive for you if you're interested.
Yeah, thank you.
I have another Daphne question before you turn off your camera, Daphne.
Down in the basement. Go ahead.
No, that's right. Well, and again, this doesn't have to be answered tonight, but I am really interested to learn as universal pre-K gets rolled out, how I saw in the director's report, there's a reference to working with preschool providers around completing, past the 2.5 hours of coverage, how that's going to work for folks. So that kind of wraparound or follow-up care for beyond what universal pre-K is providing. So that would just be of interest to me, and we don't have to talk about it tonight.
Sure, we can do that another time. That'd be great.
Cool. Thank you.
Mm-hmm. Thank you.
So I was reading the emergency management section, which sounds like and I think we've talked about this before, but the rebuild and the refocus post-pandemic. Are there specific areas of emergency response where we feel like we're behind than others? Like, are there more significant gaps in certain areas, or is it pretty much across the board there's a rebuild going on?
I think it's pretty much across the board. I think what Chris is really focused on right now is making sure that we have a response org structure, an incident command structure, that staff are prepared to fulfill those roles, that we have the spots identified, that we have sufficient staff in those spaces, I think he has in mind to do a little scenario planning this fall. But we've had so much turnover in the agency that there's also some kind of onboarding catch up to do. And he and Carrie Middleton have been doing trainings on ICS 100 and 700 several times over the summer, and they've gotten a lot of the staff back up to speed. So they're just really trying to kind of solidify us back in that space in a confident way.
Okay, great. I would love to see this kind of continue to be reported on, and I think it has been. But
and it will be.
Yeah.
Any other questions on director's report? Okay. And we are on to item 8, old and new business.
I do want to thank Greg and Morgan, who were able to make the Healthy Community Awards last week. I know you would have been there if you could have been, and appreciate that very much. It was a great ceremony. It was, oh my gosh, how many, Joe? How many awards? 13? 13. So Joe really coordinated a staff team to put the ceremony together and did a fantastic job. The commissioners were there too. And it was just a really nice opportunity to thank our community partners and reflect on the big year for us.
It was really inspiring. It was really nice to be there, I have to say. Like, it was great. I felt moved many times. Like, wow, people are doing.
And just a heads up that we are on October 21st, we're going to be having a Family Connects luncheon in Denver, where the Family Connects International folks are going to come and help launch that initiative. If any of you would like to attend, we would be happy to extend an invitation.
Will you send it? So we can, yes, we can check.
I saw Joe, did I see that Grace is leaving?
She did, she was.
Yeah. So she's going back to finish her master's.
Yes.
Grace Hood, is the climate change. I don't forget the title, but she's been really active in the Metro Denver Partnership for Health. But there's a climate change committee. So since she started, she was really active and kind of helping to co-chair that group. And so, yeah, on behalf of that group, we're sorry to lose her, but
We're sorry to
totally
see that.
understand.
Yeah.
She's did some good work for us while she was here.
Right.
Heat plan.
Yep.
And getting us started organizing, which is good.
All right. Well, good luck to you, Grace. Wherever you are. All right. And then that brings us to adjournment. It is now 7:32.
So official.
Wow.
Right.
Thank you all.